The topic is aortic stenosis, and there is obstruction of flow of blood from the left ventricle into the aorta. There are several other causes of obstruction, which could be above the valve, that is supravalvular, or below the valve, which is subvalvular. In aortic stenosis, the size of the orifice gradually decreases, and the orifice of the aortic valve, normally the cross-section wise, is around 3 centimeters square, and as the size progressively decreases, there is also a development of a pressure gradient across the valve. As there is valvular obstruction, the pressure inside the ventricle goes up, and the ventricular wall hypertrophies, and there is left ventricular hypertrophy along with increase in left ventricular and diastolic pressure. As a result, there is a decrease in compliance, and there is subendocardial ischemia and pulmonary congestion, and there is basically a ventricular contractile dysfunction and a diastolic dysfunction. The ejection fraction is reduced, and presentations are most commonly angina, syncope, and dyspnea, especially on exertion, exercise intolerance, and pulmonary edema at a later stage. Angina is basically due to reduced coronary perfusion and increase in oxygen demand, and often there is syncope experienced on exercise situations wherein the cardiac output is not increased to sufficient levels, and there is a decrease in the PVR in those situations during exertion. And heart failure results because the afterload placed on the myocardium is excessive, and also the myocardium, when exposed to severe pressure overload for a sustained prolonged period of time, leads to a contractile dysfunction and a diastolic dysfunction. Well, there is a delayed carotid upstroke and a soft single S2 and S4, and then a forceful apex beat, which is sustained, and a systolic ejection murmur. So the pulsus parvus et tardus, which is basically a late peaking and diminished carotid upstroke, is a very significant finding. And regarding the murmur, it's a systolic crescendo decrescendo murmur, a diamond-shaped murmur, which is basically heard best at the right upper sternal border, and it radiates to both the carotids. And the important thing about it is that the later the peak, basically the more severe the murmur is, as the time to peak intensity correlates with the severity. The murmur may be conducted to the apex, may have a musical quality. It's called as the Galliverdin murmur, and this Galliverdin's phenomena may therefore give a false impression that the mitral regurgitation is present. As the aortic component of the S2 is often absent because of the stenosis, the P2 component might be present only, and this is normally soft. And if A2 is there, it's very much reduced in intensity. Due to left ventricular hypertrophy, the compliance is reduced, and the reduced left ventricular compliance would result in a S4, and there could be an ejection sound close to after S1, and that would signal a bicuspid valve. And the intensity of the murmur of an aortic stenosis would decrease with hand grip and Valsalva maneuver, whereas there would be an increase in murmur intensity of aortic stenosis with squatting and with amyl nitrite. Etiology-wise, it could be due to rheumatic heart disease, wherein there could be an aortic stenosis, but usually associated with mitral valve disease as well. And there could be another cause as a bicuspid aortic valve. In a congenital bicuspid valve, basically the aortic stenosis develops at an earlier age than in patients with tricuspid valve, and an aortic root structure are usually abnormal, and there's often dilation of the aortic root, and that might require a repair as a result of rupture or dissection. This is a common cause of aortic regurgitation as well as aortic stenosis, and usually present in 1 to 2% of the population. And a murmur might be present since childhood, but the aortic stenosis usually develops in middle age with calcification. And folks with this condition are more prone to endocarditis than folks with a trileaflet valve. Now, the etiology is degenerative calcific disease. Here, the leaflets get thickened, and earliest manifestation is a aortic sclerosis, and then there progresses to stenosis, and the risk factors are very similar to coronary artery disease. So etiology-wise, there is a calcific or degenerative valve issues. Then there is bicuspid valve as an etiology, and rheumatic valvular diseases as another etiology. And apart from congenital bicuspid valve, there could be a congenital unicuspid valve. Chest X-ray would show pulmonary congestion, especially in advanced stages of aortic stenosis. One could see the aortic cusps being calcified, and there could be post-stenotic dilation of the ascending aorta. There could be left ventricular hypertrophy and cardiomegaly, and calcification of the aorta or the coronaries. ECG would show left ventricular hypertrophy in many cases, and left atrial enlargement, and then atrial fibrillation, and then STT wave changes. Echocardiography helps decipher the morphology of the valve, and also helps in the measurement, the Doppler measurements of the outflow tract velocity, and velocity helps to um, look into the gradient. TTE and TEE are the uh, are often utilized, and TTE helps to look at the leaflet numbers and the calcification issues and the morphology, looking into the valve areas and the gradients, the mean and the peak gradients. And severity of the aortic stenosis can be pretty much looked into by the parameters as the peak jet velocity or the valve area or the mean gradients. One could utilize TEE to look into a valve. If it's a bicuspid valve, it's not very clear on a TTE. And in looking into the left ventricle, the left ventricular outflow tract obstruction, additional reasons that could lead to left ventricular outflow tract obstruction. Often exercise testing is done to to basically look into exercise-induced symptoms, or to look into the exercise capacity, or look into a blood pressure response which is abnormal, in the sense that with exercise there is inadequate rise in the blood pressure, and and in folks in whom the symptoms are not very clear. Cardiac catheterization, often done in symptomatic patients, it helps measure the gradient across the valve, and also helps to confirm the diagnosis. Also helps detect any coronary artery stenosis that may coexist and that may need bypass at the same time as aortic valve replacement. Also to look into and evaluate for any coronary artery disease in folks with symptoms of angina with moderate aortic stenosis. Often the BNP or NT-BNP levels are useful. The BNP levels are higher in patients with true severe aortic stenosis when they compared with a pseudo-severe aortic stenosis. Then in true severe aortic stenosis, the BNP is higher and also helps to predict the survival in folks having this condition and are having low flow and low gradient aortic stenosis. And it also helps predict symptom free survival in asymptomatic patients. Medical treatment wise, diuresis and sodium restriction if there is congestive heart failure, and to control the rate of atrial fibrillation. Calcium channel blocker verapamil may be useful in the control of rate in atrial fibrillation, and one should avoid overdiuresis and loss of preload. Uh, Make sure not to precipitate hypotension, and utilization of vasodilators, particularly nitroglycerin, should be done very cautiously in order to avoid any hypotension. And if there is hypertension, then treating with appropriate antihypertensive agents has to be done very cautiously to avoid any hypotension. And in folks with severe aortic stenosis and decompensated heart failure, um, in order to bridge the patients to a more definitive treatment, that is surgical management, that is a AV valve replacement, one can utilize during that period IABP or sodium nitroprusside or balloon aortic valvuloplasty. Valvuloplasty may help in along with IABP and nitroprusside in afterload reduction, and in folks with severe aortic stenosis with decompensated heart failure, these these options may help bridge the patient to definitive surgical management. Balloon valvotomy provides a temporary relief, though. This treatment option is basically it's a palliative measure. It's a palliative treatment option um, in folks with serious comorbidities, and but in situations where there are young adults with non-calcific aortic stenosis, and in those kind of situation, balloon valvotomy is a viable option. Surgical treatment is an effective treatment, and it is currently the only effective treatment in cases of symptomatic severe aortic stenosis. And surgical treatment is basically utilized in situations such as symptomatic patients with severe aortic stenosis, or in patients with severe aortic stenosis with left ventricular dysfunction, which systolic dysfunction, ejection fractions are low, and in folks with severe aortic stenosis undergoing CABG, or in folks with severe aortic stenosis undergoing surgery on the aorta or other heart valves. Regarding the valves, there are basically the mechanical valves which have the greater durability and a lower rate of failure, and they are associated with lower all-cause mortality, and they need lifelong anticoagulation therapy, and with warfarin and aspirin, and they are associated with increased risk of infections and thromboembolism, whereas the bioprosthetic valves are used in situations where their folks are contraindicated for warfarin therapy, and there are non-compliance issues. There is no anticoagulation required. There's another procedure uh, in which there is autograft being used at the aortic valve position, and again, these folks do not require anticoagulation. And of course, in folks with moderate to severe aortic stenosis, vigorous exercise should be discouraged, and in situations where folks don't have any symptoms but do have a high gradient, then surgery is not a routine for such situations.